He also
Oh,
works a
good
lot
night. Good
on
night.
oral cancer.
Okay.
He actually works on chronic inflammation and oral cancer. He's been doing years of work. Like you have been doing years of work on PVL, he's been doing some 20 years, I think, on this. So, ma'am, you
Yes,
are
very
being
nice to
missed.
see you.
Okay, everyone, I'm going to take off this little video and we're going to try ma'am's PowerPoint so that we are better set for the beginning of the program. Okay, ma'am. So this is how it's going to look. Can you forward the slide from your end?
Um,
Just try.
okay. I'm just using my arrow and it's not moving.
See, there is this on the screen itself. Can you see there is where it says slide one? Can you see that arrow
On the
on
screen.
the where you can see right now our pictures and your
Yes.
PowerPoint
Yes, I can
on
see
the
the
shared
PowerPoint.
screen? Okay, can you also see where it says below that where it's coming and saying if you just hover your mouse on it, can you just
I cannot see anything. Is it at the bottom? Oh, it's moved now. Are you
I just
moving it?
moved it. I just
Okay.
moved it, yeah.
How do I move it?
Try.
No, where do I click to move it?
Okay, 1 second. So, right at the bottom of the slide, where the slide is showing, in the center at the bottom, you should be able to get a list.
Because there are just
Sorry, that was
messages
again me.
that's coming in, but I cannot see anything that says I can move the slide. There is
Okay.
there's an area that I think will expand my screen.
Yes,
Okay,
okay, just try that.
my screen is expanded now, and stop
Any luck?
broadcasting, share,
Nothing?
nothing that I can do to move it.
Okay. So, what I will have to do is I will have to share it for you, I guess. Okay, no
You
worries.
will have
I
to
will
move
share
for
it.
me. You
I
will
will
have to.
move it for you. Yeah. Yeah,
Yeah,
I
the
will.
only thing is I wanted to show, so I guess I'm unable to show. I mean, I was
Yeah.
gonna use my arrow to show things,
Yeah.
but it's okay. We'll try and work it out somehow.
Okay.
I'll just say next, please, if I want it moved.
Yes,
Yes.
absolutely. Yes,
Okay then.
totally.
Thank you.
Okay. Okay, we are fine. And let's see what's the time. Why don't I have? Oh, we are already late. Okay. Let me just sort of. Okay. All right. So I need to now share. Okay, do we have that? Yes, we do. So, oral potentially malignant disorders are really the most important thing if you think about in terms of stopping or diagnosing oral cancer early or hopefully preventing it from progressing to being oral cancer. And this has been around for a long time. They have been very significant. They have helped us in a lot of ways. And initially, it was very straightforward. We had this situation where you had from the white lesions a thin, uniform white lesion progressing to thicker, progressing to mixed with red, and then progressing eventually. If you went along, a line of progression to malignancy, then erythroplakia was the standard considered as the most likely to turn malignant. We often found malignancy within erythroplakia. Then came around along PVL, and it sort of upset that whole setup because now it's a white lesion, but it is considered to be also highly likely to progress to malignancy, to oral squamous cell carcinoma. Now, exactly where those PBLs stand, there is a lot of information, but somehow it's not clear. So today we are very lucky to have Dr. Rosnah Zain with us because she has been working on this for a very, very long time. And let me welcome you to this episode of the Update series. And with that, we have a little about Dr. Zain, where she is the currently the dean and also professor and of the Department of sorry, Oral Pathology and Oral Medicine in the MAHSA University, and she has founded the Oral Cancer Research and Coordinating Center of the Malaya University. Also continues as the advisor to the same organization. She's a fellow of numerous prestigious organizations, past president of the Malaysian Association of Oral Diseases and the Asian Society of Oral and Maxillofacial Diseases. Ma'am, I'm very happy to have you here with us. It's a truly an honor.
Thank
So
you.
you're welcome.
Thank you, Dr. Mandana, for having me.
You're most welcome, ma'am. It is entirely our privilege. So let me now again find that. Sorry, I have. Yes, we are there. Okay. So, ma'am, I will just stop my camera so I'm not an unnecessary distraction there, but I'm right here. Yes, you can start.
Okay. Okay. Thank you, Dr. Mandana, and welcome to everyone. Thank you for that introduction. Actually, it is just an interest. I'm not really working a lot on it, but I'm quite intrigued by the different types of lesions that is in proliferative verrucous leukoplakia. So I've taken an interest since 2003 when my colleague Dr. Nassim Ghazali and me actually wrote a paper to look into about nine of the lesions that we had in Malaysia, and at that time we only had the one or two groups of people who had put up the criteria for this proliferative verrucous leukoplakia. So what I'm going to do here is just to go through what I have done, and probably to relook at what I have done, and then I will try and present one case to actually show how that we can use the criteria to assist in the diagnosis. And in terms of a lot of papers are actually more from the non-Asian regions, but there are quite a number of papers from Asian regions. But the papers uh, on the criteria and all that are yet to come from the Asian region. And I just have a few issues that I wanted to put up when we deal with lesions in our region. So next. Okay, so I'll just start off with the WHO 2017 Blue Book, which has a definition of proliferative verrucous leukoplakia as that it is a distinct entity and aggressive form of or potentially malignant disorder. It is multifocal, it has progressive course, and is associated with high recurrence and malignant transformation rate, and 70% or more develop invasive cancer. Next, please. And there are four clinical stages, which are focal flat white keratosis. And this is the important part that I wanted to stress when I was doing our trying to fit into the criteria. Diffuse multifocal white patches, slowly progressive horizontal and exophytic warty verrucate surface, and development of verrucous carcinoma or squamous cell carcinoma. Next, please. So, in terms of histopathology, there are a very varied histopathology, which goes hand in hand with the clinical, and though it is localized flat or verrucous hyperorthokeratosis. So, some of those white lesions, flat lesions, can be either uh, minimal or no dysplasia, and then there can be a progression into advanced stage of atypical verrucous hyperplasia. So some people find that it's very difficult to call verrucous hyperplasia, because verrucous hyperplasia in itself also has been used also almost interchangeably as histopathology and clinical. And so some had diagnosed it as atypical and dysplasia during late stages, and they progresses into verrucous carcinoma or conventional squamous cell carcinoma, and frequently shows interface mucositis, band-like lymphohistiocytic infiltrate subjacent to basal cell layer. Next. So the diagnosis of PVL would really require a clinical and histopathological correlation. I don't think there's anything that says this white lesion is a PVL and this histological picture is PVL, because it is a combination, and there is a lot of correlation that needs to be done, consideration that needs to be done, and thus why the need for criteria. And for a while, understanding the criteria is the issue, and a few people, a few authors have come up with some guidelines to criteria which may be of help. So you can actually have a white lesion which looks can be flat, can be a little corrugated, and with that you could actually have, as in the histopathology below, which is orthokeratosis, and you actually see a verrucal lesion, and you see also a band of lymphocytes, which is what was described earlier. And then you can also, in the next clinical picture, it's supposed to be a verrucous carcinoma, but at the clinical picture stage, if it is this wide, you probably would say, yes, definitely this is verrucous carcinoma. But sometimes it just appear as verrucous clinically, and therefore, and yet it is not as a wide an area. And so in terms of clinical diagnosis, that would probably have been called verrucous leukoplakia, or many have actually called it verrucous hyperplasia. And many years back, we had redefined the clinical, we started a terminology for this clinical to be exophytic verrucous hyperplasia, only because we recognize verrucous hyperplasia is a histological term, but we could not find a terminology to use as a clinical terminology before you actually get a biopsy. Therefore, we have a group of us have decided that it's exophytic verrucous hyperplasia. But that is just a terminology of a lesion that actually could be in proliferative verrucous leukoplakia. And why we actually said exophytic verrucous hyperplasia instead of just keeping to just verrucous leukoplakia is also because we do get this type of lesion which is not white, which is papillary. Okay, so that's just adding on to I'm not going to talk too much about exophytic verrucous hyperplasia, but I'm just saying that this is how a group of us have defined and look at that lesion. It can be single within, not within proliferative verrucous leukoplakia, or it could be within proliferative verrucous leukoplakia, but it is only at a clinical stage. By the time it is biopsied, it will probably fall into the groups of verrucous hyperplasia, verrucous carcinoma, or squamous cell papillary squamous cell carcinoma, or even the conventional carcinoma with papillary surface features. Next. So, going back historically, the first publication was by Hansen et al. In 1985, where he described specific non-homogeneous light of verrucoid subtype with extremely high propensity for malignant change. And he also noticed benign multifocal homogeneous leukoplakia persistent and slow growing, and the unknown etiology. And at that time, he was not associated with risk factors. Although as we go along, there may be risk factors within this PVL, especially in the Asian region, but so far it has not been part of the criteria. Next. Hansen et al. Actually set name five clinical pathological spectrum of PVL. It can any of this can happen at any time, and first is homogeneous leukoplakia. The second is whether it's verrucous leukoplakia or verrucous hyperplasia. This is where I was talking about just now. If it is white, this is verrucous hyperplasia, verrucous leukoplakia. If it is not white, it is verrucous hyperplasia, and we can call it exophytic. Although in our definition, we actually say exophytic verrucous hyperplasia to cover both the white, which is verrucous leukoplakia, and the non-white, which is as exophytic verrucous hyperplasia. And clinically, depending on some criteria, it can also be verrucous carcinoma, although definitively needs to have a biopsy. And it can also be a papillary squamous cell carcinoma. Again, this is actually a histopathological diagnosis and poorly differentiated carcinoma. So all in all, the 4 and 5 clinically would probably be mainly carcinoma, and inclusive of 3, except that 3 may have more specific features to be able for us to say that clinically is verrucous carcinoma. However, all of it would definitely need it is a clinical provisional diagnosis and would need the histological diagnosis to to get the final diagnosis. So that's why it is a clinical pathological spectrum. Is actually a combination of clinical description as well as a pathological description. Next. Then in 1999, Batsakis revised the version of Hansen's PVL spectrum to 4 stages, which is clinically flat leukoplakia without dysplasia, non-homogeneous leukoplakia with dysplasia or verrucous hyperplasia, and then the verrucous carcinoma and squamous cell carcinoma, omitting papillary squamous cell carcinoma because it is just a specific entity, and it's not as common because many of the squamous cell carcinoma, if it has papillary features, would probably be conventional squamous cell carcinoma with papillary features, unless they actually have very specific features to be diagnosed as papillary squamous cell carcinoma. Next. Then in 2010, the Serrero Lapidra came up with a structure of how to diagnose this by naming them into major criteria and minor criteria. And the major criteria is a leukoplakia lesion with more than 2 different oral subsites, usually gingival, alveolar ridge, and palate. If you notice, the flat lesion, white lesion, or leukoplakia lesion is not mentioned here. Here it is just talked about lesions in 2 subsites, and the condition is to also have a presence of a verrucous area within the lesion, and the lesion which have spread or engrossed during the development of this disease. And there is a tendency for this lesion to have a recurrence in previously treated area. And here it comes as histological presentation with simple epithelial hyperkeratosis to verrucous hyperplasia, verrucous carcinoma, or squamous cell carcinoma in situ or infiltrating. So the histological presentation is almost here similar with the Hansen et al., where you actually have simple epithelial hyperkeratosis. And then minor criteria were also considered, It is an oral leukoplakia lesion that occupies at least 3 centimeter when adding all the affected areas. And the patient is a woman. The patient does not have the habit of smoking. Again, this is a minor criteria at that time, but I think more of the um, published cases now do actually show smoking. And here they name the period as disease evolution longer than 5 years. Next. And in 2012, the Karat et al. Actually modified the criteria to actually just keep it to leukoplakia, showing the presence of verrucous or wart-like areas involving more than 2 oral subsites. The following oral subsites are recognized: dorsum of tongue, border of alveolar mucosa or gingival lower jaw, hard and soft palate, and floor of mouth and upper and lower lip. So it's almost all areas. So when adding all the involved sites, the minimum size should be at least 3 centimeters. And there is a well-documented period of disease evolution of at least 5 years, being characterized by spreading and enlarging and the occurrence of one or more recurrences in previously treated area. In view that there's so many of these lesions, I think that there is a tendency that there may not be documentation, and this is also, I think, one of the issues in many centers in the Asian region. That is earlier. I'm sure by now most are more into documenting this. The availability of at least one biopsy in order to rule out the presence of verrucous carcinoma or squamous cell carcinoma. And then in 2018, the next one, Villa et al. Also put up these white keratotic lesions that may be smooth, fissured, verrucous, or erythematous with or without ulcer, multifocal non-contiguous lesions or a single lesion of more than 4 centimeter involving one side or a single lesion of more than 3 centimeter involving contiguous side, lesions that progress or expand. So here we are also talking about progression or expansion, and a histopathology, if not overtly exhibiting dysplasia or carcinoma, shows hyperkeratosis, parakeratosis, atrophy, or acanthosis with no minimal to no cytologic atypia. KUS is the keratosis of unknown significance. This is coined in Suk Bin Wu's paper, with or without a lymphocytic pan or verrucous hyperplasia. And these features must not support a diagnosis of frictional or reactive keratosis. So these 4 criteria, I think in a more recent publication, these 4 criteria were looked at, and I will talk about it later, and a scoping systematic review was done to look at what would be the best criteria by looking at these 4 criteria, and then by having questions asked about this criteria, and then by taking all the publications that satisfy a certain of the criteria of the scope of the scoping, and then coming up with final criteria. So I will at the end be having the finding or the outcome of the scoping, which I think will cover most of this. But for now, as we are working on this, I'm just trying to go through now to back to my the publication that I had with my colleague. Let's move on to the next one. Okay, but before that, in this Villa et al. 2018, there's a suggestion to be called proliferative leukoplakia because there seem to be quite high, the 18% of 22% are fissured, and therefore it may be more appropriate to call them proliferative leukoplakia because there are other features other than other than the verrucal features. There's also areas which has got red areas, and they also named it as proliferative erythroleukoplakia (PEL), and so that there is this suggestion to not use proliferative verrucous leukoplakia, but maybe used to better describe proliferative leukoplakia with prominent erythema, which has the highest malignant transformation rate similar to erythroleukoplakia, and it has a high association with dysplasia and SCC. But I think for now, the proliferative verrucous leukoplakia is still widely used. Okay, next. So I'm just going to go back to 2003, where in the Malaysian case study, there were 9 cases where the criteria of Hansen's was applied, and as there were no documented diagnosis of simple homogeneous leukoplakia with absence of dysplasia as a first presentation. These cases in that paper was just as suggestive because that criteria was not satisfied. But as you notice, later the other criteria actually do not specifically mention the need to start off with this simple homogeneous leukoplakia. And the thing with our cases is that they come late. And it could be that there may be a simple homogeneous leukoplakia at the start, which we do not see because patients come in already at their moderate or advanced stages where they have multiple lesions, which is a combination of the simple homogeneous leukoplakia or the verrucous hyperplasia or even the carcinoma. However, 3 of the cases were more towards proliferative verrucous leukoplakia. So these are just pictures to show that there can be a flat lesion in the first picture, a flat white lesion, and in the second picture, it's more of like a swelling, more exophytic, although it's not a close-up, but it is a bit papillary, but it looks more like a carcinoma. And in the third picture, there is 2 areas, one more white than the other, and they all have very papillary surface. So in this publication, we have actually questioned whether these are proliferative verrucous leukoplakia at that time, just using the Hansen's criteria. So right now, just picking out we had in the publication, I'm just going to show you how we try and fit into the future, the later definition that is from 2010 onwards, and actually could put this into proliferative verrucous leukoplakia. In fact, at that time when we were doing this, we were suggesting that we should not have a starting point as of simple homogeneous leukoplakia, but rather for as a criteria. It may be retrospectively has a starting point, but we should actually have a criteria of a number of lesions. So we'll move on to the next one. And so the 3 cases, we decided then that it was suspicious of PVL as the early changes, flat leukoplakias with no dysplasias, are not detected. And we think that many cases in the Asian region at that time or a bit after that may not satisfy this criteria, especially in the aspect of early lesion, which is the flat leukoplakias with no dysplasia, because they may be presented late, or it is truly that they don't have such early lesions. So let's move on. So I did an exercise that I looked back at the criteria. So all the cases when we originally did was doesn't satisfy the first one, but it satisfies all the other aspects, which I have already mentioned before. And many of the patients are non-smokers, but they do have bitter quid chewing habit for 2 cases, and this was also not highlighted in the publications at that time. Next. And then I tried to re-evaluate, especially these 3 cases. So when we use the Serrero Lapidra et al. 2010 criteria, it all satisfies the criteria for the first one, leukoplakia with lesion with more than 2 different or subsites, presence of verrucous area and lesions which have spread or and growth during the development of these lesions and recurrence in a previously treated lesion, and histological presentation of simple epithelial hyperkeratosis to verrucous hyperplasia. Because in these cases, we do have simple epithelial hyperkeratosis, but we did not see it at the beginning. At the beginning of the lesion, because as I said, we may have not got it, or it may have just started with the other lesion. And an oral cooperation lesion that occupies at least 3 centimeter when adding all the affected areas. And this is the minor. The first 5 is a major. Patient is a woman. Most of our patients are women, and the patient does not have the habit of smoking and disease evolution longer than 5 years. So ours was satisfied that criteria, our follow-up period. So next, we'll go into the evaluation by Karen et al. And it is the same, except that the criteria here is that everything, leukoplakia showing the presence of verrucous or wart-like lesions involving more than 2 subsites. So this is quite a simple criteria that we could have used. And then when adding all the involved sites, the minimum size would be at least 3 centimeter, then progression to develop multiple lesions, histological progression. And here, they actually also have scores, development of new lesions following treatment and follow-up period. So the next one, so this satisfy all the criteria. So we move on to the next one. And this is the 2018 criteria, also followed all the criteria. But as I said, you notice that the only criteria that at that time says that it normally begins with flat lesions. Once it's not that criteria, then most of them is quite easy to fit into all these criteria. So we move on to the next one. And so I would like to just quickly go through one case that I have had I've had in my collection, and but I've not published, and it's a group, a number of pathologists and surgeons are involved. So the patient is 76-year-old and the patient is female. The patient had a chief complaint and history of presenting complaints of white lesions in the mouth since 6 years. So the patient never really came came to seek treatment or diagnosis. And the patient used to be a bitter quick chewer but had smoked. So when when we first see the patient, we actually straight away sees a whitish exophytic lesions with areas of erythema at left alveolar mucosa and ridge of right floor of the mouth with right homogeneous lesions. So there's already a number of lesions that we see, and the histological presentation is moderate epithelial dysplasia, a verrucous hyperplasia with severe dysplasia, and that white excision was done. And in July, another lesion, ulcerated lesion over the right floor of mouth. This is a new lesion, and that turned out to be verrucous carcinoma. Whilst in the same month, we also have white papillomatous, in 3 years later, we had white papillomatous lesion, which was actually diagnosed as verrucous papillary lesion or verrucous hyperplasia, exhibiting moderate dysplastic lesion, but it was excised at that time. Next. And as we go on, within that same year in December, the pedunculated growth at the gingiva in left retromolar area region, as well as leukoplakia and buccal mucosa. And histologically, it is a verrucous carcinoma, and then the buccal mucosa was a severe dysplasia. And at that time, these pedunculated growth were retromolar region, excisional biopsy, while the treatment was deferred because it was like December, so a few things had to be looked at, and that was deferred to February. And then and in March there is also a white verrucous lesion, which is a verrucous hyperplasia. So I just try to relate this clinical and histological, and just try to show the extent of and the challenges that we face when we actually see a patient with that many lesions. And these challenges are also challenges that we see to put them together, and to see what is happening, and therefore the need to actually document this. So we move on to, I just have a diagrammatic drawing of things. If you go along with that, I think you will see. I tried to make them color coded in terms of their diagnosis. For example, there is we had first a white homogeneous lesion that is actually um, uh, the yellow one is actually just epithelial hypoplasia. It's just got epithelial dysplasia, all right? And then at that time, there are three lesions. And the blue one is actually verrucous hypoplasia. And then as we move on to, as I said earlier, there is a new lesion, which is ulcerated. Then 12 months later, there is this white papillomatous lesion, which is actually here verrucous hyperplasia there. And then verrucous in 24th December 2014, that's at the end of the year, there is a new lesion, which is a verrucous carcinoma. But this new lesion may be arising from this area where we, in slide number 2, the 15 November, where we actually have the verrucous epithelial dysplasia already. Okay, and then the area where we had in the left buccal mucosa, non-homogeneous area, was biopsied, and that was a severe dysplasia. And then again, as we described earlier, there was a white papillary lesion where there was a white excision, and that was a verrucous hyperplasia. That is on the sixth visit, where that will show that. And the leukoplakia in the left buccal mucosa showed severe dysplasia and was actually removed on the 25th March 2015. So we move on to the next one. And here, this is when this was removed. And then later, there is a development of verrucous lesion at the commissure angle of the mouth. And this turned out to be verrucous hyperplasia with severe dysplasia. And these, yeah, that's better. So that's at the eighth visit. And at ninth visit, there is excisional biopsy done. And 1 month later, we still see that the lesion is there, and that was considered as residual, and that was finally removed. And there is also a whitish homogeneous lesion in the left buccal mucosa, which is, I think the color has sort of changed a little, which is a recurrent lesion, considered a recurrent lesion from the previous time. Next. So this is in 2016. That was the last follow up that we've done, and these are lesions that is still there, which is a verrucous hyperplasia. And this is the right corner of mouth. Sorry, I actually, can you just make this a little smaller? I'm just trying to read the thing underneath. Okay, that's okay. I can't see that. You can bring it bigger. Anyway, so that's the 10th visit. We have this lesion as well as the lesion on the buccal mucosa. Next. Can we move on? Next, yeah. So so that's just to show the complexity of trying to follow through proliferative verrucous leukoplakia. And of course, when we started, we with 3 lesions, we think, okay, this possibly is a proliferative leukoplakia, and so prospectively we follow up. And so, as we apply the diagnostic criteria by Hansen, again, if we apply that leukoplakia with no, we didn't have that from the start, and areas with original homogeneous leukoplakia acquiring verrucous surface, we don't have that from the start, but it satisfied the other two criteria. So initial presentation was multifocal non-homogeneous leukoplakia, did not evolve from a homogeneous leukoplakia with no dysplasia, and a diagnosis of PVL according to criteria by Hansen et al. In this case will only be possible retrospectively, assuming that patient's initial lesions that was present 6 years ago before the development of verrucous lesions was a homogeneous leukoplakia with the benign hyperkeratosis. And therefore, this patient was followed prospectively. Next. Okay, then when we applied the Serrero Lapidra et al. Criteria, it all fits in except for the bitter culture, and yet that is just a minor, which we by now would be able to already diagnose this as proliferative verrucous leukoplakia. Next. And similarly with the Carrot et al., they all satisfied the criteria. And lastly, the Vita, next one. The next, yes, Villa et al., they all satisfied the criteria. So, so by now we are quite confident that this is a proliferative verrucous leukoplakia, and of course, if we had not considered the criteria that it must start with a benign leukoplakia, then we would already have been confident even if using the Hansen's criteria. Next. Therefore, the issues here are the diagnostic criteria useful in early diagnosis of proliferative verrucous leukoplakia? I guess if you looked at a single lesion, then it's not useful. But if you see, like in our case, we had 3 lesions at the same time, and you can't even call that early diagnosis because that's 6 years ago. The patient didn't come, and will grading PVL help to predict malignant transformation? I think there's a number of papers now that is doing this, but I'm not sure that we really have a grading of PVL. We probably grade the different types of lesion. Is there any benefit in early diagnosis, as most PVLs are aggressive and refractory to treatment? Again, I think we need to look at all the methods or the treatment methods to be able to answer this. And I think yes, definitely there would be a benefit because you will ensure that you detect all this lesion early and you take treatment. And is surgical treatment practical because of widespread oral mucosal involvement? I think this is an issue, especially in situations where these patients are quite elderly. And I think in the scoping paper, it actually shows that there's a tendency to be above 60. Do we need to consider adjuvant therapies if PVL is diagnosed early? I think I have not really done a good search on the management, but I think there may be a lot of papers on this that we can look into. Next. So, just looking into the updated literature, I was quite. I find this paper by Gonzalez Moore et al. In 2021, very interesting and really describe a lot of issues. There are a lot of questions, and they actually work on how they answer that. And what they had done is they had done a systemic review search and then put up the criteria, and out of the search they have selected 24 publications that they will use for this, and then they put up all the 4 criteria that I've mentioned just now, and they start looking into questions on whether these criteria, whether these suggested criteria have got the different aspects, and then put in the 24 papers, and then they come up with an outcome which is also an outcome that brings in also their expert opinion, because this is, I think, at a special consensus meeting. So what I wanted to put here is that after all those criteria, this is what I find most interesting, is that we can now say that a proliferative verrucous leukoplakia is a potentially malignant disorder that presents in the form of multifocal plaques. That's number one that we have considered, which have expanded through its evolution, and that also have been mentioned in one or two of the criteria. And it is persistent because even with treatment, it is there, and one of two of it is resistant to treatment. And this is the thing that is not mentioned in most of those criteria, is that they are usually diagnosed in people in the second half of life. They found that most of these people are above 60. And as I keep harping on just now, that these things, as in my case, 6 years already the patient had lesion, but we never looked at it. I mean, we've never seen it because it probably begins in these earlier stages. And yes, they confirm that this has a very high risk of developing oral cancer. I think some talks about above 50%, but I've showed earlier that now they believe that it is way above 50%. That's what we in the WHO is written as 70%. So I feel that now when we are thinking of the proliferative verrucous leukoplakia, when we put uh, our lesions and everything together, I think this is a good working statement or definition where we can look at those things that I have highlighted in color. Okay, next. And just before I finish, just to talk about proposed management of PVL, this is not treatment per se, but what we should consider. One is to ensure that we have a proper diagnosis. Two, to ensure that we choose the best treatment. So photographs should be taken at every visit. So I would like to say that in my case, there was lack of photography. I mean, I have histopathology because those are done in the lab that I was in then, but the clinical pictures probably somewhere, but the ones that I could retrieve is only those two, which was at the end. Patients should be closely followed up every 3 to 6 months, and biopsies that show only hyperkeratosis, parakeratosis, epithelial atrophy, or acanthosis, or which is named as KUS, keratosis with unknown significance, with or without inflammation, may be followed only. That means there's possibly no requirement to remove it. But gingival leukoplakias is special. It will be treated on a case-by-case basis, because many other factors impact treatment. For example, the age, physical health, degree of involvement, bone loss, tooth mobility, and the appearance and behavior. And next. Okay, continue further with proposed management. Areas that show mild to moderate dysplasia can likely be observed if it is felt that completely removing the area is not possible because of the extent or location of the lesion. And if the area is discrete, excision can be attempted. Areas that show severe dysplasia or carcinoma in situ should be excised, especially if the area is discrete, such as nodular or verrucous mass within a fissured and relatively homogeneous area. Margin will likely show mild to moderate dysplasia. So these are sort of things that was published by Villa et al. In 2018. Again, there may be more publication. I've seen more publication, but I'm unable to sort of summarize and put it here. Next. Next. Yeah, so the areas of concern is that there's poor reproducibility between pathologists in a collaborative study, and they need to be able to reliably recognize PVL, critical because of the high potential of malignant transformation and follow-up, and problems in interpretation of varied diagnosis of oral maxillofacial surgeon and implication on treatment. Next. So future studies in the Asian region, we need to look into a large number of cases. There are studies, large number of cases, but I think we needed more studies, such studies in the Asian region, and most cannot be included with past diagnostic criteria. But I have to say that by now, most can be included. So criteria such as Carrot et al. Can be used, which may cater for diagnosis of more PVL cases in the Asian region. And once standard criteria accepted, progression of these cases in Asia may now be studied. So these are the future studies on PVL progression that I had done prior to actually seeing this more recent publication on scoping. And now I think that is a good reference to use to possibly go through doing this kind of study, and definitely the need for calibration. Next. So I think I've done this twice, so let's move on. Let's move on. So in conclusion, yeah, just backward, yeah. The issues in PVL diagnosis that we may want to think of is the about bitter quick chewing, and um, the need to consider the criteria of PVL in the Asian context and inter-observer variability. So with that, I really would like to thank you. And I'm very sorry there's a noise in behind. I told them not to do it. If you excuse me for a minute, I'll tell them to stop. You can hear the
Yes,
noise.
ma'am. Yes.
Yeah.
Yes, I can. Yes. Yes. So that was an interesting one. So in the till ma'am comes back, let's see who else is with us. So, of course, we have people today from all around the world, as usual, the US, South America, from Myanmar, from Nigeria, is what I saw. And yes, of course, from India. Right. So, please do put in your questions here, and we shall deal with them in a few seconds as soon as ma'am comes back. The first
I'm so
one.
sorry about that. I can't even trace the source, but I hope they will stop for a while. Yeah.
It happens. Okay, ma'am, that was a wonderful presentation, and we have a few questions here. One is from Dr. Nasser, and he says it's a great study, and he wants to know whether you have checked possibly, or whether anyone that your studies you have seen, they have checked the presence of HPV. In fact, this is a question that is also raised by Dr. Wynn. The same thing, whether there is a relationship with HPV and malignant transformation.
The
Anything?
the paper that we did in 2003, we did try to relate to HPV, but we were not able to. But to my mind, I think we haven't got any relationship, but I may be wrong because I've really not fully looked at most of the updated papers. There's quite a number of updated publication. Yeah. Perhaps someone in the audience know better than me on this, can perhaps give us an input.
Yes, that would be nice. We also have a message and a comment from Dr. Akshay. He is asking as PVL is multifocal and considering the fact of field cancerization, is it advisable to take biopsies from all the lesional tissue as carcinogenesis can be an independent event?
Yeah, I do share your concern. However, the fact that this is PVL, there's already field cancerization, and therefore there is a need for us to actually a need for us to have a definitive diagnosis. I personally feel that we still need to do it. I mean that the field cancerization definitely is there. Yeah.
Yes. Then we have Dr. Lassos. Very interesting lecture. In our service, we have seen cases of oral lichen planus, both clinically and histopathologically, that on follow up become full-fledged PVL. What is your experience on this?
I really have no experience on this, but I think I've seen publications that has uh, this. Although in our cases, we do see striae and all that, but we have actually not put it as a lichen planus. And as you see that the histology do have the subbasal lymphocytic infiltration, which is one of the criteria for lichen planus. So until we actually have a starting point of lichen planus, and then it becomes a full-fledged PVL. Yes, I think that's what you have. It's from lichen planus to PVL. But otherwise, if it is a mixed number of lesions with some areas with showing striae, I think we need to be careful about diagnosing that as lichen planus becoming fully fledged PVL.
That sounds very correct. I have one question that I don't know, maybe you or someone in the audience may have an answer to. And that is, has anyone tried to identify the genetic changes? Could it be that these patients basically have a genetic mutation, maybe in the suppressors or something like that, which is why they have multiple lesions? One of your cases I saw, the patient had multiple cancers in due course of time and in a very short span of time. So, and considering they are verrucous carcinomas, which are not supposed to be that aggressive. So,
Yeah.
anything that you have found on this?
Yeah, so far I have not, but I also would like to hear from the audience. I'm sure there are people who have worked on it. As I said, I was strictly more looking into diagnosis. Yeah.
Right, true. I don't know if anyone in the audience has worked on this. Yes, it's a very interesting topic, ma'am. Actually, yeah, I must say, because it's sort of changed so many things. And I mean, it. I know it was the first case was in '85, which is definitely a long time, but it made so much of a difference because we had that clear picture that, in that's what I would say, in that line where we put all the, if we had to put all the pre-malignant lesions on it, it was the red ones. When it went to red and it, whether mixed or purely red, that it became more malignant. We never thought of leukoplakia as being at that in that category, being in that level. But this has totally changed that, and it of course makes a lot of sense. So, okay, let's see. They have some more. Okay, that's the people who are enjoying this, and Dr. Win is also asking about EBV,
Yeah, I also
Epstein-Barr
am not
virus.
sure about that. Yeah.
Yes. I
I
think
need someone else to help me.
yes, we are discovering a lot of topics that our young colleagues can now go and study. Yes, we also have,
There can be potential topics,
exactly.
with arising from this, because with all those questions, you can have more webinars on it, right?
Yes, absolutely. Now we can, with all these questions, we should have a panel discussion now, I guess. Yes, we have Dr. Tilak Ratne also. He enjoyed the
Thank
lecture.
you. Thank you, Dr. Tilak.
Yes, and
Hi.
Dr. Meher is here from Fiji. Thank you. And Dr. Osmani, if PVL is the treatment only in, mm,
Not sure what you
I'm not
mean by
getting what is that.
pathology.
And can't get that. Okay. Wow.
Okay. Yeah.
Okay, there's interesting. There's even bacteria stuff, genetic changes. Okay. Okay, that's really, that one I had not expected. All right. So, okay, I don't know if there are any more, anyone has any more questions or suggestions. Again, now we mostly have people saying that it was a great presentation and thank you. Yes, thank you,
Thank
Dr.
you.
Nawal.
Yeah, well,
So,
okay.
yes,
Thank
I
you.
guess we have done the presentation is done. Now just give me a second and I shall just have to share again. Did we get that? Yes,
Thank
I
you so
think we
much.
did.
Thank you for the
Thank you,
details.
ma'am. Thank
for the
you.
flowers.
It is really
Now
wonderful
I
to
wish
have you with
I'm
us.
there physically to get the flowers.
Yes, absolutely. Hopefully, when we meet next, I will definitely give you a big bunch of flowers.
Okay, thank you. Thank you so much
Most welcome.
for inviting. I've also enjoyed doing it because I have to go back and look at all those cases again. Yeah.
Yeah, it's always interesting to suddenly think about something all anew. It brings so many more thoughts in there. That is very interesting. So now coming to the further things of our presentation, just a few minutes of everybody's time. So we are coming up with another event on storytelling, and I know some of you must be wondering why storytelling. But frankly, I think it's very easy for us to understand that storytelling makes a difference. And we, as pathologists, and a lot of people among us are from oral medicine, we have seen the power of stories, the power of building a narrative. We are still fighting an old narrative, the one that the tobacco companies created. A story that has caught on so much that after years we are still fighting it. And that was a narrative that wasn't even true. So if we build a narrative and it is scientifically true and we are just bringing the emotion into it, making people care, I'm sure we can power dentistry. We can power it to be able to get patients to listen to instructions, get students to pay attention. Maybe that editor who reads the covering letter and then gives up and doesn't read your paper may be inspired to actually read the whole paper. There are a lot of things, and we can achieve all of that. So, anyway, we have an event, and you can find out more about it by scanning the QR code. I hope you'll join us. It's on the 3rd, and I think it's going to really be very interesting and something that we should look at on how to build a narrative around the science. And for everybody who has been following the oral pathology scene in India, you might have noticed that in the last month we have been having a flurry of events. There have been events, and there are events going on almost every day for the next 4 days too. And that is because it is the 25th of Feb is Dr. Dholakia's birthday, who we consider as the father of oral pathology in India. And this month has been the oral pathology month for the most part. Now we are going to wrap up the month. So on the 1st, that is next Tuesday, we are going to have an event with two recognized faces of oral pathology in India. We all know Dr. Hazare, of course, and he's going to be there to share a little bit of history with us. And we also have a young colleague who is really coming up and doing a lot, and he's going to share with us a little bit of the current scene. And I do hope you will all join us for this event on the coming Tuesday. With that, I'm going to say thank you to everybody. It's been lovely to have you all with us. I do hope you will continue to spend time with us and join us. uh, your attention, your subscribes, your links, your comments, the shares of the events is absolutely what keeps us going and keeps us coming back week after week. We have over 100 videos now. So this has been a very interesting journey with you, and I hope we will continue it too. Thank you so much. Bye. See you all next time. Bye. Bye, ma'am. Bye.